The next question we're going to look at focuses on organ donation and specifically how we decide which patients should receive a new organ. So we're going to look at a kidney transplant and help use ethical frameworks to decide whether one or two patients should receive a new kidney. So we've got patient A, who is a 20-year-old boy who has been very fit and active throughout their entire lives. Their only medical problem is end-stage kidney disease caused by diabetes. So far throughout their life, they haven't made any incorrect lifestyle choices that could negatively affect their health. And that's about it as far as patient A is concerned. Patient B is a 75-year-old man who smoked from the ages of 20 until 60. So throughout that time, they were smoking about 10 cigarettes a day. They also consume a large amount of alcohol, so they drink about 20 units of alcohol a week. Alongside type 2 diabetes causing their end-stage kidney disease, they also have chronic obstructive pulmonary disease, COPD, and ischemic heart disease. So you're given this scenario where you are asked to decide who between these two patients should receive a new kidney. So I think firstly, within the setup that you were given, there could actually be a bit more information you could gather. So you need to figure out what type of kidney transplant this is. So there are live donors and deceased donors. Once you've asked a bit more information about the context of where the donor is coming from, whether it's a living or deceased donor, you'd then want to try and gather as much information you could about each of the patients. If the interviewers would give you more information and they would let you dig in a bit more, then try to do so. So try to get as much information about the medical history of patient A and patient B, and obviously in the setup they're trying to tell you that patient B has made some bad lifestyle choices, and on top of that they might have some other medical issues that could make them a poor donor. You would then want to try and tell the interviewers the features that could make patient A or patient B a suitable candidate. So the most important aspect to consider firstly when examining organ donation and patient suitability for it is whether they're an appropriate match. So if patient A or patient B are a different blood group to the patient who is donating the kidney, then it's a non-starter. They just simply cannot have the kidney because it won't work. Alongside blood groups, you can also think about their HLA genes, so human leukocyte antigen. There are 3 different types, and ideally you want all 6 HLA genes to match between the donor and the recipient patients. So the next aspect you can consider are quality adjusted life years, also shortened to QALYs. These can quite often be used not just in donations but in all aspects of medicine, but 1 QALY is essentially 1 year of standard healthy life. And 1 QALY is obviously what all of medicine is aiming to achieve. Whenever we treat a patient in any which way, or whenever we do anything in medicine, we're always trying to maximize health and get as many QALYs as possible. We're trying to get as many people living a normal, healthy year of life that is without any reduction in the quality of their life through the diseases that they're experiencing. So if you live a year, which is a full year, but your quality of life during that is 50% of your normal healthy quality of life, then you get half or 0.5 QALYs. Again, if you get 6 months at normal 100% quality of life for your age group, then that would be, again, 0.5 QALYs. We can use QALYs in the context of organ donation because we can think about how many QALYs we are going to add to each patient's life if we give them this kidney. So obviously when we think about QALYs, patient A, who is 20 years old and has a lot more life ahead of them, as opposed to the 75-year-old who has less life ahead of them, is more likely to benefit from more QALYs. So when we're thinking about QALYs and where we're going to get the most benefit from donating this kidney, the 20-year-old patient A is going to be the more suitable candidate, purely looking at the QALY perspective of things. Quality adjusted life years can be very useful for helping us decide how we should allocate medical resources, because we're always trying to maximize the benefit that we have with our limited resources. So one philosophical idea behind this is utilitarianism, the idea that you want to get the maximum benefit for the limited amount of resources that you have. You want to get as many people living as full and happy a life as possible. The difficulty with utilitarianism is deciding how we divvy up the difference between quantity and quality of life. So would we rather make 1,000 lives 1% happier, or would we rather make 1 life 100% happier? It can be quite difficult to balance the difference between quantity of life and quality of life. Tying QALYs back into our question, when deciding between patient A and patient B, while patient A will have a much higher number of QALYs added to their life if they potentially receive this organ, they are useful to bring up when talking through your answer and discussing it with the interviewer. Organ donation systems can use them, but in the past they were a little bit too relied on, and therefore that led to a bit of age discrimination in who did receive and did not receive organ donations. So in your answer, I would advise mentioning QALYs and being aware of them, but not necessarily using them as the only way you would decide who receives the organ. So alongside the appropriate match of the patient and the quality adjusted life years, we can also think about the patient's health in general. So patient A was 20 years old and had no other medical conditions, and patient B was 75 years old and had a few medical conditions going on. When you receive an organ, that is a surgery and that has appropriate risks going with it. You want to minimize the likelihood that a patient is going to come to significant harm from anything that you do in medicine, and taking into account a patient's comorbidities and the diseases that they have is an appropriate part of that. So patient B had COPD, they also have ischemic heart disease, and that increases your risk of having a surgery because of the ability of the body to tolerate the stress to it and just generally overcome the difficulty of the operation. Alongside that, there are other risks associated with the anaesthetic, and the recovery process tends to be a bit slower. So mentioning an awareness of the patient's comorbidities and saying that you wouldn't want patients to come to harm, so bringing in non-maleficence and saying that if there's an unacceptably high risk in operating on patient B, potentially, then you might not want to operate on patient B to prevent them from coming to harm from the operation that you have. You don't necessarily need to have an in-depth knowledge of how diseases influence your risk with surgery. What you just need to demonstrate is an awareness of a patient's suitability to have an organ received and to have a surgery taken, and that the older you are and the more diseases that you have, that will carry a risk of there being some sort of complication from the surgery. Okay, so lastly, autonomy. So a big part of this question is the decisions that these patients have made around their healthcare choices. You want to demonstrate an awareness that healthcare should be delivered on the basis that patients are allowed to make their own healthcare decisions, and not all of those are good, such as smoking or drinking excessive amounts of alcohol. These should not be taken into account in the context of organ donation. Now, there are some lifestyle choices that do influence organ donation, and by that, that's usually receiving a new liver in the context of excessive drinking causing liver failure. So if a patient has got liver failure due to excessive alcohol consumption over their lifetime, if they are still drinking alcohol, then they aren't a candidate for a liver transplant. Outside of the context of alcohol consumption affecting liver transplants, I personally haven't heard of any other lifestyle choices affecting a patient's ability to receive an organ. In the context of the interview, when comparing patient A and patient B, you want to clearly say that on the basis of autonomy, that their healthcare choices should not be affecting their suitability to receive an organ, because on the basis of autonomy, then patients are allowed to make poor healthcare choices. And again, on the basis of justice, we want a fair and equal distribution of the resources amongst our population. So when you're going through your response, there isn't necessarily a right answer to which patient should receive the organ. It would be reasonable to say that the younger patient who has more potential for life ahead of them should be the recipient. However, if they're not an appropriate match, then you shouldn't be considering them in the first place. The most important part of answering this question is to show an awareness of the principles of utilitarianism, an awareness of quality adjusted life years, the principle of autonomy, that patients' decisions shouldn't be affecting their ability to receive healthcare in general. You don't necessarily need to say definitively patient A or patient B. If you show an awareness of all of those factors and their suitability to receive the donation in the context of their overall health and put that across to the interviewer, that's all you need to do.